everyone, and welcome to YSLAAH-20Q. My name is Induwari Jinadasa, and I am the current president of the Youth Sri Lankan American Association of Houston. Today I'm joined by my co-host Oditha Palayangoda, as we have the pleasure of speaking with Dr. Rasi Wickramasinghe, MD, PhD, FACC, and interventional cardiologist. In this conversation, we will explore Dr. Wickramasinghe's career journey, insights into the field of cardiology, and advice for students interested in pursuing a career in medicine. Now let's get started. What inspired you to pursue a career in medicine?
Well, I come from a medical family. Back in Sri Lanka, my dad is a pediatrician, and my sister is also a pediatrician. I had an interest in science and biology all throughout my childhood, so it was somewhat of a natural process for me. I kind of thought that I wanted to go into medicine early on, and had a knack for biology and science. So honestly, I couldn't think of any other field I'd be happy in.
When did you first realize you wanted to become a doctor?
That's a little bit more of a different question. So I've had multiple ins and outs in my desire to be a doctor. So when I was when I lived in Sri Lanka, obviously, I thought I wanted to be a doctor because that's pretty much the only trajectory you could take. However, you might know this, that there was a civil war going on in Sri Lanka, and I was in school, finishing school, entering medical school around that exact same time. So due to some of the troubles that we had after I had finished my university entrance exams and gotten into medical school, there was a 3-year hiatus where we had to just sit and just wait for medical schools to reopen. Mm-hmm. During this time, I took my SATs and applied to colleges here, mm-hmm. and unexpectedly got a full scholarship from Stanford. Mm-hmm. So once I got a offer to come to the U.S., I knew that it was going to be for undergrad, mm-hmm. because there was no transition from undergrad to medical school in Sri Lanka. Right. And then I debated whether I wanted to give up medicine, and I decided that I did want to give up medicine, mm-hmm. and I came here with the intention of becoming a scientist. Mm-hmm. So my interest when I was at Stanford was in molecular biology and developmental biology, and I did a lot of research on that, and then went down the path of becoming a scientist, mm-hmm. until later on some of my mentors suggested to me, if you really want to be a good scientist, it would help to also understand medical science, so maybe you want to consider being a doctor as well. Mm-hmm. And so I pivoted again, mm-hmm. and then decided to go to medical school. So if your question is when I first decided to be a doctor, it was probably when I was in Sri Lanka, mm-hmm. but my decision to become a doctor had been pivoting back and forth. I made another decision, so I'll just finish up. From my time at Stanford, after I had decided I wanted to be a scientist, mm-hmm. I went to a graduate school program to do a PhD, mm-hmm. and paid no attention to medical work at all. And it was during this time that my wife got sick. We had just met, and we were dating at the time, and she got very, very sick, and I was a PhD student. Mm-hmm. And when she was sick, I realized that I don't understand a word of what the doctors in the room were talking about when they were taking care of her. And so at that time, I thought to myself, you know what? I do want to go and become a doctor again. Mm-hmm. And so I sort of resolved that if she got better, I wanted to be a doctor and try to be good at it. So once she did get better, I finished my PhD, went back to medical school, and then decided I want to do a combination of both, doing research as well as taking care of patients.
Mm-hmm. How did you prepare during high school and in college for medical school?
The preparation was obviously very different. High school preparation was geared towards getting into medical school in Sri Lanka, which is different than the trajectory I had here. So when I came to the US and finally decided I wanted to apply to medical school, my preparation was based on I actually took the philosophy of taking the most challenging classes I can without paying attention to what grades I was getting. Mm-hmm. I was lucky, I did well for the most part, but one of the key things that I did to prepare also is get myself familiarized with the types of experiences you can have in medical school. Mm-hmm. So I did quite a bit of work in clinical medicine when I was in college. And more importantly, I think that I spent a lot of time doing basic research in a lab. Mm-hmm. I think it was perhaps those two things that really helped me move to the next step.
Mm-hmm. You earned both an MD and a PhD. What motivated you to pursue in both degrees?
Yeah, most of it was indecisiveness. Mm-hmm. That's the truth, because I really couldn't make up my mind whether I wanted to become a scientist or a doctor. Mm-hmm. And I figured, well, if I can't decide, why not do both and see which path I take. Yeah. Part of it was also financial. My personal history is I came to this country as a non-citizen, so I wasn't at Stanford as a foreign student. Mm-hmm. And my parents were not financially well off enough to send me to medical school here. So one of the things I was looking at is what are the avenues that are open to me to go to medical school. And one of the things I found is that MD, PhD programs in this country are funded by the National Institute of Health. So it's called the MSTP, or the Medical Scientist Training Program. And in exchange for doing a PhD and becoming a scientist and training in that, the US government pays for medical school. There were some complications that happened around that. I was, for example, not aware that the US government money did not apply to non-citizens. Mm-hmm. I then learned the hard way that it did. But the main reason I decided to do an MD PhD was really, truthfully, financial. I figured that would be the only way I could go to medical school while without having the burden of my family pay for it. Mm-hmm. But it was an added bonus that leading up to that point, I was very much interested in science and research as well as I was in medicine. Mm-hmm. So it was a no-brainer. I mean, if I could do both, I'd do both. Mm-hmm. And that's essentially what I did.
Mm-hmm. Why did you decide to specialize in cardiology?
Again, my initial pathway was not to cardiology. My PhD wasn't even in cardiology. It was in neuroscience. I was fascinated in the brain and the molecular biology of the brain. But when I did my PhD in neuroscience, I did a lot of in-depth work in a mouse model. So basically genetically engineering a mouse that had some abnormalities in a particular protein that was expressed in the brain. So I modified the genes of this mouse to see when you remove that gene, what happens to the brain development. Mm-hmm. And so the nice thing about science is that the best discoveries come unexpectedly. And one of the unexpected discoveries I made is that when you took that gene out of the mouse, when we were expecting a phenotype or an outcome in the brain, mm-hmm. most of the abnormalities in the mouse was in the heart. Mm-hmm. And that was very unexpected. Mm-hmm. So my PhD advisor at the time told me, well, I mean, there's obviously a much bigger, so in medicine, there's this thing called phenotype and genotype. Okay, genotype is what you get when you remove the gene. Mm-hmm. Phenotype is the manifestations of that. What is the defect that you see? Mm-hmm. And so this mouse's phenotype was much more prominent on the cardiovascular system. And I went down the rabbit hole learning about the heart and the cardiovascular system just to be able to finish my PhD and explain what had happened to this mouse. That got me very interested in cardiology. Mm-hmm. And so when I finished my PhD and went back to medical school mm-hmm. to do my clinical work, I gave equal attention to cardiology as I did neuroscience, and I was completely hooked on it. And to me, I think the thing that really attracts me to cardiology is going back to my indecisiveness. Mm-hmm. Even in medicine, I couldn't figure out, am I going to be a surgeon? Do I like taking care of patients and talking to them in the clinics? Do I like taking care of very sick people in the hospital? Do I like being a radiologist and reading studies in the dark? And I figured out I like all of them. Mm-hmm. And so that cardiology is probably the only field in medicine that allows you to do everything in one day. Mm-hmm. So my job, entails doing all those different things. Mm-hmm. And we can talk more about what that entails, but essentially, cardiology came from the idea that I wanted to do everything.
Mm-hmm. I'll hand over the next set of questions to Oditha.
Thank you, Induwari. What led you specifically to the field of interventional cardiology?
Yeah, interventional cardiology is a branch of cardiology that's a bit more specialized than being a general cardiologist. So if you look at cardiology as a field in general, there are three major aspects to it. There's general cardiology, which are doctors who take care of patients with heart problems. And then among them, there's interventional cardiologists, or the plumbers of the heart. We're doctors who primarily fix problems in the vascular system of the heart. So when people have heart attacks, when they have valvular heart disease, we can fix those immediately. Then the other branch, is just to give context, is electrophysiology, which is a field where cardiologists work on the electrical system of the heart. My interest in interventional cardiology came because I also happen to have a very strong family history of heart problems, and most of my relatives, and as of many Sri Lankans, have severe heart disease, and I became fascinated in a branch of cardiology, that is coronary artery disease, or disease that occurs due to blockages in those arteries. Heart attacks is the common manifestation of that. Interventional cardiology appealed to me because it's the one field in cardiology where you can actually do something and get the result within 30 minutes to an hour. So I'm one of those guys who doesn't do well with delayed gratification. I need instant feedback that I did the right thing. And so no other field in cardiology can give you that like interventional cardiology can. So this was my primary driver to go into that field.
Interesting. What were the biggest challenges you faced during medical school and residency, and how did you overcome them?
Biggest challenges? Medical school, I would say maintaining a social life with the amount of work and the studying we had to do. I think if I look back, I think residency was probably more of a challenge because I was married and had a child by that time. So my daughter was born when I had just started residency, and it was incredibly challenging. And I think to this day, probably the hardest thing to be a dad and also be a good resident, because residency is not like anything else I've ever done. And unlike most other people, you'll spend essentially 36 hours at a time in the hospital training to take care of these very, very sick people. So I think one thing that helped me overcome the challenges is knowing that the whole thing is finite, and then there is a light at the end of the tunnel, that I don't have to do this forever in 3 years or 4 years. And then as I go, become more and more senior in the process, that the process also becomes easier.
What does a typical day look like for you as a cardiologist?
Very busy. As you can see, it's 6 o'clock on Friday and I'm still here. Probably will be here for another couple of hours, but I think in general I put in about 80 to 100 hours a week. So typically my day starts at around 7 in the morning, and I will usually, depending on my day, start at the hospital, where I usually round on about 15 to 20 patients, and usually some other patients I did procedures on the day before to see them and then get them ready for discharge. Some of the other patients are the ones who came overnight from the ER who are sick, to decide whether they need any procedures done. And then usually after that I'll end up starting clinic, and then here in the clinic, which is where we are today, I end up seeing about 25 to 30 patients in the half day. And then usually then the afternoon starts, and I go back in the afternoon, then I do start doing the procedures I'm supposed to do, and usually 4:30 to 5 o'clock is when I start the documentation, which is sitting in my front of my computer and dictating all the notes from the procedures and the patients that I've seen, and then fielding phone calls from family members, from patients, other doctors who are helping take care of those people. So usually day doesn't end until about 10 o'clock at night, and sometimes, actually I would say most days, I'm still usually behind the computer finishing my documentation by about 9:30.
Interesting. What type of heart conditions do you normally treat?
As an interventional cardiologist, mostly coronary artery disease, and that's when you have a blockage in the arteries that supply blood to the heart. So the common way most people know coronary artery disease is with a heart attack. A heart attack is essentially when an artery just suddenly gets blocked. And so those are medical emergencies, which means that this is one of the other problems of, not the problems, but one of the challenges of being a cardiologist, that you don't really own your time. Because if it's one of my patients and they show up in the hospital with a heart attack, it could be 2 in the morning, I gotta get up, put my shoes on, come to the hospital right away, and do a procedure at 2 in the morning to get their arteries open back up. So the bread and butter of my work is coronary artery disease. I do practice a substantial amount of general cardiology, which is seeing people in the hospital and the clinic and managing all realms of just different cardiology, seeing their health, managing cholesterol, blood pressure, things like that, ordering tests when people have shortness of breath, chest pain, things like that, managing cardiac arrhythmias, understanding and managing valvular disease. There are two other branches of interventional cardiology that I'm invested in also. One is called structural heart disease. It's a newer field. So a lot of the patients who 10 years ago used to get open heart surgery for, say, to replace a heart valve, we now have the technology to replace that entire heart valve without ever cutting them open. All using catheters and tool wires through a small hole in the leg, which is about maybe a quarter of an inch across. So those procedures have enabled us to do very complicated surgeries, if you will, in people who are, say, even 95 years old without having any concern that they may have a problem, because this is not prolonged anesthesia, this is not large surgery. So usually these people will get valve replacements and go home the next day. And then the last category of heart disease that I work on is called peripheral vascular disease. And that's because the blood vessels in the heart and the blood vessels in the rest of the body are essentially the same. So just like you have a heart attack, if you have a blockage in the legs or any other blood vessel, interventional cardiologists can open those up and restore blood flow as well.
Interesting. What procedures do interventional cardiologists perform that not many people might be aware about?
I think what we just talked about. I think the two areas of procedures are valve replacements. Everyone thinks that valve replacements are done by general surgeons or cardiovascular surgeons. That used to be the case, but nowadays, because of the availability of technologies and minimally invasive techniques, we can replace heart valves in patients without ever cutting them open. And I joke to my patients that I can replace the heart valve without a scalpel, without ever cutting them. And that's one of the things. And then peripheral vascular disease as well as carotid artery disease are another two areas that interventional cardiologists predominantly perform.
Nice. Now I'll pass the next set of questions to Induwari.
What would you think is the most rewarding part of your work?
The most rewarding part of my work, I think, comes in at 2 a.m. when I come in, usually angry and upset that I was woken up from sleep to see a patient with a heart attack, see this patient who is at the verge of death, chest pain, blood pressure plummeting, and we know that we have probably in the order of 30 minutes to do something or they're going to die. And our cath lab team, a group of about 7 or 8 people that's with me at night, they immediately go into effect. We start the procedure, go in, quickly look at the artery, find the blockage, unclog the artery, put a stent in, open it up. And then within 30 seconds, that same patient who was dying, suddenly the chest pain goes away, blood pressure comes back. And then 35, 40 minutes later, since I woke up, they're being wheeled out of the procedure area, smiling in their face. Family members are relieved, and I drive back home with an incredible amount of relief that we was able to save someone's life that day. I don't think there are a lot of jobs that can have that level of high within doing something for 30 minutes.
Yeah.
So I think that's probably the most rewarding part of the job. But in addition to that, I follow patients for years and years and years. I mean, I often have patients who sometimes meet me for the first time when they were having a heart attack, and then they follow me for years because they come and get checkups. They introduce their family members to me because they like what they see, and then their family members become my patients. And next thing you know, I'm like one of their family members because I know their brother, their sister, what happened to each person, who's getting married, who's not. That longitudinal contact I have with patients is also very rewarding.
What are some of the most challenging aspects of being a cardiologist?
I think the most challenging aspect is that you need to have a very, very thick skin. And you need to be okay with seeing people dying, because for every person whose life we can save, there are lots of people whose life we cannot. And one of the hardest things for me as I was making the transition from a junior cardiologist to becoming a senior one is being okay with that. It's extremely hard once you've known someone, say, for 5 to 10 years as your patient, and you end up doing a procedure on them because you're having chest pain, and during the procedure something goes wrong and they go into cardiac arrest and they die. And then you have to walk out of that room and tell the family that, yeah, dad just died. That never gets easy, no matter how experienced you are, but you do need to develop a thick skin, because if you don't have that thick skin, I think that just the tension of the job will absolutely destroy you.
Yeah. How many hours do you typically work per week, and does your schedule change frequently?
Unfortunately, no. I think if you're saying how many hours a week, it depends on what you mean by a week, because as I tell my kids, it's not like people don't get heart attacks on the weekends. Yeah. They do. So my job is essentially 24/7, 7 days a week. There are times when I need to go on vacation, for example. I will pass on my care, a patient's care, to other doctors, my partners, and they will go and address those issues if one of my patients have concerns. But that doesn't take away from the fact that I'm literally on call 24/7. My phone never stops ringing. 2 in the morning, 3 in the morning, sometimes if it's a heart attack. If it's not a heart attack, just because someone who I'm taking care of in the hospital is having a serious issue and the nursing staff and the hospitalists who are here don't know how to take care of it, and they're calling me to ask what to do. So it's not continuous work, but it's a lot of interrupted work that happens all the time. So I think altogether, I'd probably say at least 80 hours a week, at the very least, if not usually more than that. But yes, being a dad is extremely hard with this job, because, as you probably know, I barely get time to participate in any of my kids' activities, because I may be at a birthday party or a school event, and then I get called away because something more pressing happens. So it's a lot of work, but it's rewarding.
What skills or personal qualities are most important for someone who wants to become a successful physician?
For a physician, I'd probably say compassion. You really need to be a very compassionate person to understand that when you're getting called in the middle of the night, it's not because someone wants to disrupt your sleep, it's because someone really needs you. It's important to be someone who has a lot of perseverance, right? Because none of these skills come easily. You've got to learn them, and someone has to be very, very persistent. So I'd probably say being compassionate and being persistent, being perseverant, hardworking, diligent, paying attention to details, because details matter in this field. Those I would probably say are the most important qualities someone needs to be a successful physician, and even a cardiologist.
Which high school or college subjects help prepare you the most for a career in medicine?
That's a tough question, because I'm going to say something that's completely off base here. It's not science or biology or math or chemistry. I would probably say, of all the things that I studied in college, the one thing that helped me become a good doctor and a cardiologist is probably comparative religion. And I say that because what makes you a good doctor is your ability to connect to other people. And at Stanford, I was initially forced to study comparative religion. And I say forced to study because I came from Sri Lanka expecting to have a science-based curriculum. But comparative religion was put on my lap because I was asked to say, you got to study the Bible, you got to study the Torah, the Jewish Bible, the Quran, the Bhagavad Gita in Hinduism, Buddhist texts, and so forth. The reason I think that was most important is because that gave me the ability to connect with people who are from very dissimilar backgrounds. Well, some of my best experiences is sitting down next to someone who's dying and quoting from the book of Job in the Bible. And I'm not a Christian. They don't know that. And that education gave me the ability to connect with them, because as soon as they feel like you're able to connect with them at that level, their trust in you as a doctor just goes through the roof. Same thing with someone who's Muslim, and I can easily pinpoint things from the Quran and a lot of people are surprised, and it's not because I'm smart, it's because I was very lucky to have that education. So I think, going back to your question, it's not biology, math, or chemistry, or physics, or any of those things that people normally think makes you a good doctor. It's the unusual things that you normally don't associate with medicine.
I'll pass the last set of questions off to Oditha.
What advice would you give to high school students who are interested in becoming a doctor?
Go shadow another doctor, because I think the biggest misconceptions that high school students have is that they look at doctors' lives on the outside and they think that's what being a doctor is about. Medicine is a lot about grit as it is about glory. A lot of people see the glory part, they don't see the grit part. They don't see how many years of persistent, grueling training you go through without making barely any money before you get to that point. And I think a lot of people are disenfranchised when they get to that point, that either they didn't expect that to be reality. So my advice is, if you really want to be a doctor, shadow a doctor. But shadowing is not what most people think it is. It's not going 9 to 5 in a clinic and saying, adios, I'll see you, I gotta go home right now. Shadowing a doctor is getting into my shoes, living my life. Of all the high school students I've had shadow me, 99% have come in at 9 o'clock in the morning, stand with me with clinic, come to the procedure room, watch me do procedures, then go around with me. Only one has told me that if you get a heart attack at 2 in the morning, call me, I'll come. That's the person who knows what it's really like to be a doctor, because it's not the 9 to 5, it's everything that happens beyond that. I think that's hard. So one piece of advice I would do is, whatever specialty that you think you have an interest in, or is if it's just general internal medicine or pediatrics, yeah, you can shadow doctors in clinic, but shadow a doctor, because it's very different than what you think it might entail.
Interesting. How has cardiology changed since you began your career?
It's changed a lot. The biggest changes, I would say, is technology. We have the tools that we use today, the procedures I can do, we did not have access to it when I started. And as a result of the tools that we have, things that were unfathomable just 10 years ago, we do on a routine basis. For example, I'll give you an example. The valve replacement is a great example. We could not dream of replacing someone's heart valve. So if someone was 89, 90 years old and was too high of a risk to have open heart surgery, 10, 15 years ago, we would just say, I'm sorry, you're gonna die and there's nothing we can do to stop you. We don't do that anymore. We can actually offer them solutions that they didn't have access to. Even from a technical standpoint, doing these procedures, if I had to open an artery and the arteries was filled with calcium and I couldn't get a stent in, we would have to put a drill through it and drill through the artery before we can put a stent. And the risk is that there's a substantial risk that the drill would just perforate the artery and the patient would die on the table. We still use the drill, but we have newer technologies. We have these really cool technologies called shockwave balloons. These are balloons that we implant and inflate inside the artery that have little electrodes that deliver ultrasonic energy to the calcium and just bust the calciums, just like you do in kidney stones inside the kidneys. So the technological advancement in cardiology is the number one thing that I've really become fond of and just can't wait to see what happens in the next 20 years. And then it's the incorporation of artificial intelligence. In cardiology, AI is making inroads a lot. I mean, in general medicine as well. About up until a year ago, I used to have a usually a high school student called a scribe who would come with me. And he or she is usually someone who wants to go to medical school, so wants to get a letter and wants to know what cardiologists like, so they'll be my note taker. So that way I can focus on talking to the patient. And we don't use those anymore because our note taking is done by AI. So I have my phone sitting in the room while I'm talking to the patient, and the phone listens to the conversation. When I walk out of the room, the entire note is written.
Well, interesting. While we're on the topic of technology, what new technologies or innovations in heart care excite you the most?
How things are getting perhaps more and more minimally invasive. The level of invasion into the human body and things that we're doing is getting smaller and smaller and smaller. I predict that in about 10 years, we probably won't be putting stents into people. The technology for that is already here. We call those drug-coated balloons. These are balloons that deliver a medication to arteries that are diseased, so that once you've inflated that balloon, you no longer need to put a stent in. They're using that technology already in Europe. It hasn't made its way to the US, but the clinical trials are in place. I think that will be a real game changer because, part of the problem with having stents is that once you put a stent, it stays with you for the rest of your life, and it's metal. So I think 20 years from now, or even 30 years from now, we'll look back at what we're doing now and maybe think of it as the barbaric 2020s when we put stents into people, because I think the world is moving in a very different direction.
Earlier, you mentioned something about artificial intelligence.
Mm-hmm.
Do you think artificial intelligence will change how cardiologists diagnose and treat patients?
Absolutely. Yeah, I think so. We're already seeing it, right? So AI is making our lives a lot better in terms of offloading some of the work that we're required to do because of the economics and business of medicine. Hardest part of my job is not taking care of patients, it's the documentation part so that we can get paid from insurance companies. AI is taking the brunt of a lot of that work and helping with documentation, billing, things like that, following up with patients, the automatic messaging. I think from the procedural standpoint, I don't think that AI is mature enough to be completely autonomous. It's not there, not at all, not by a long shot, despite what Elon Musk says. I think that it'll probably take another decade or two before we get to that point. But it is coming. I think eventually there's probably going to be a time where an autonomous robot can put a stent in if you have a blockage. It's not there, nowhere close. We do have robotic stenting now, where a physician can stand behind a robot in an enclosure and control the robot and do those procedures. So there may be evolution in that technology, but I don't think it's matured enough to be completely autonomous.
If you could go back, would you still choose to become a doctor? And what continues to motivate you today?
100%, I would. Despite the fact that I question my career decision almost every night when I get called at 2 a.m, I think that if I could do things all over again, I still probably would be a doctor. And I think it's because the one thing that medicine gives that no other job gives is a level of satisfaction that you really made a difference in someone's life and still get paid for doing it. I don't think there's a single other field. Teaching does the same thing, I would imagine. Make a difference in someone's life, but you don't get paid for it the way doctors do. So I think medicine is unique, that you get compensated well and you really make a lasting difference in someone's life.
Dr. Wickramasinghe, thank you again for sharing your time, experiences, and valuable insight with us today. It was truly inspiring to learn about your journey in medicine and your work in cardiology. On behalf of the Youth Sri Lankan American Association of Houston, we sincerely appreciate your willingness to be part of our YSLAAH-20Q career interview series. And thank you to everyone watching. We hope this conversation helped provide insight and inspiration for students looking to be in this field. Stay tuned for more interviews featuring professionals for a wide range of fields.
Thank you.
Thank you.